I think my job will be to convince everyone that Destandau itself is more than enough for doing most of the spinal pathologies. So as such, evolution is the basic of nature. Evolution results in development of ecosystems which has multiple entities. These entities, they tend to collide with each other, they compete with each other, and then lastly result into an entity which has the tendency to actually endure all the challenges which are offered by that ecosystem. These entities may not have one single advantage, but these are the entities who have advantages of multiple other entities. This is one of the things that has allowed human beings to actually dominate this ecosystem for such a very long time, and the virtue by which it is possible is because of the versatility. So the same evolution process applies to endospine also. Good afternoon everyone, I am Dr. Ashutosh. I am Assistant Professor in Department of Neurosurgery, SGPJ, Associate Editor Journal of Spinal Surgery, and today I will be discussing about how Destandau system is highly versatile and it allows you to address most of the spinal pathologies. Secondly, what was the limitation because of which it could not be kept into the 4th generation endoscopy, and lastly, what was the modification that we did that allowed it to be the 4th generation and rather beyond 4th generation. So in 1990, when Jean Destandau actually introduced this Destandau system, it was a major revolution in the endoscopic spinal surgeries. Since then, the system itself has evolved within it such that the spectrum has greatly widened. Where it started just for the extradural pathologies, now we are actually doing the intradural pathologies and even intramedullary pathologies also with the Destandau system. This is just one example where we had actually addressed a completely extraforaminal neurofibroma just by using a Destandau system. And you can see very well, the clarity is really good and the lung can be seen very well just pulsating under the pleura. We have already published our experience of how Destandau system can be used to address all the compartments of spinal disorder, that is the extradural, intradural and even intramedullary at cervical, thoracic and lumbar region. So this proves why the Destandau system is actually highly versatile. The first 2 generation endoscopy allowed us to do discectomies. The 3rd generation endoscopy allowed decompression for spinal canal stenosis, while the 4th generation endoscopy allows us for the lumbar interbody fusions. Destandau itself has a very defined working port which is limited. Because of that, the large cages cannot be inserted. So there has been certain modification like putting a K-wire through the working channel and then letting it into the intervertebral space, and then under C-arm guidance you can pass the cage. However, the problem with that is that the cage insertion is actually blind, that is C-arm guided. So we did a little modification in the process where we use the usual systems, the same usual system that we use in Destandau or MISSABCON and perform the fusion. So this is the case that illustrates this technique where the 33-year lady had presented to us with backache and left L5 radiculopathy following a fall. Examination suggested there was EHL weakness and associated sensory loss. The imaging confirmed an L5S1 listhesis and there was a left paracentral disc. A part of disc was going into the foramina and also was up migrated. So we planned it for our patient in general anesthesia and was position prone. Standard draping was done, and this is the skin markings that we make: the midline incision, the lateral pedicle lines on both the side, and the end plates. The insertion, and we also use a needle that helps us to direct what will be the direction of the docking. This is very helpful because it also prevents the number of C-arm shots that we'll be requiring. The incision in this case is paracentral and it is different from the usual discectomy incision that we take when we do Destandau thing. The docking is done and it is confirmed with C-arm. The docking is done at the spinolaminal junction and then working laterally along the L5 lamina, we come to the L5 inferior facet. So here the usual monopolars have been used, and here we have reached the lamina facet junction, which is called as the valley between two mountain view, where we have the L5 inferior facet, superior facet, and the gap in between. Once this is done, then the inferior margin of the L5 lamina is removed. Then we do a strategic 3-point drilling that involves first drilling the inferior edge of the L5 lamina. Then the second point drilling will be laterally onto the pars intra-articularis that will help us to completely disconnect the L5 inferior facet. And lastly, in the root of the spinous process that will allow over the top decompression and even decompression on the other side. So these are the 3 points. Afterwards, when the bone is thinned out, using Kereson's upcut, then we remove the remaining bone. Working laterally, it has now disconnected the L5 inferior facet. This inferior facet now it needs to be removed. However, it is always attached with multiple ligaments that need to be meticulously removed. Once they are removed, this large piece of bone needs to be broken down into smaller pieces. Then only it can be taken out from the outer sheath of the Destandau. So here are these two pieces. They are later on used to pack the PEEK cage so as to improve the fusion. So here we can see the now naked S1 superior facet and the ligamentum flavum. The ligamentum flavum should be kept till all the bony procedure is done. The drilling of the S1 superior facet should be very, you should be very careful because you may end up injuring the S1 pedicle. Afterwards, the ligamentum flavum can be removed in piecemeal or en bloc. Afterwards, the further dissection is done. Here the thecal slag is visible. Now dissecting laterally, the traversing nerve root is exposed. As we can see, the field is not that bad. Actually, if we are doing hemostasis at each and every level and proceeding to the next level only after the hemostasis is achieved, the vision is actually good and no further actions are required in that. Once the retraction is done, the underlying engorged venous plexus can be seen. It can be coagulated with usual bipolar or even you can use RF. The level is confirmed using C-arm. Because here we have to do fusion, we'll do a large, we make a larger corridor into the annulus fibrosus using a 15 number blade. Afterwards, an aggressive discectomy is done. Care is taken because in this case there was an up migrated disc also. So we have taken all the care that all that part is removed. Then the system is converted. Then we use the upper pedicle screw there where we'll be putting. We'll use the same incision and then we'll first incise the skin, then the fascia, and afterward we use dilators. This dilator we have to triangulate at the end of the Destandau system. Now the triangulation is done under direct vision. Here we are actually seeing the dilator going inside. We keep this dilator at the intervertebral disc space, which gives it the stability and prevent any compression of the nerve root. Afterward, the serial dilators are inserted, and this is the last dilator that we put. These are the same dilators that we are going to use for insertion of the screw. Now the endoscope is passed into this dilator. This prevents any kind of soiling of the endoscope. Afterwards, the inner sheath of the Destandau system is removed. The outer sheath can now work as your expanded corridor. We can even remove this outer sheath because now the corridor is already formed. You can maneuver all your instruments through it. Now even the largest possible shavers can be passed through the working port. Thus, the discectomy process is actually hastened. Now the endoscope, here we are inserting into the intervertebral disc space itself to see what the completeness of the end plate preparation. This is a large sizer that we have inserted, and you can see there is no separate retraction of the nerve root that is required. And all this procedure is being done under direct vision. We have inserted a 12 by 22 millimeter PEEK cage that has been already packed with the bone that we had harvested. In this case, we had to use a slight retractor to slightly retract the nerve root so as to prevent any injury from the serrated margins of the cage. Once the cage is inserted, care is taken to remove all the small fragments of the bone that may have dislodged from the cage. Afterwards, we can complete the over the top decompression. In this case, we did not need to do over-the-top decompression because there was not much of canal stenosis. It was mostly traumatic. This is the status at the end of the procedure with the thecal sac and nerve root being supple and easily and pulsatile. So overall, we took only 4.5 hours, and total estimated blood loss was 300 ml, and the duration of hospital stay was 5 days. This is the clinical outcome and the radiological outcome. So this endoscopic MISSABCON with Destandau technique has multiple advantages. Firstly, that you don't need any other instrument. Whatever instrument that you have, you can perform the procedure with that itself. It does not require any recurring cost and no new cost itself. Secondly, because it's a dry system which we are already used to in doing the interlaminar work, or those who are already doing MISSABCON, the same instrument, the same exposure is required. However, it does have certain limitations in the form that there is a steep learning curve. Sometimes you will have to use a 30-degree endoscope, and retraction of nerve root may not be completely avoided. So I must say that Destandau system offers you that one kick. If you practice multiple times, it will make you the master of it, by which you can actually address most of the spinal pathologies. So these are my references, and I'm thankful to my alma mater and mentors and all the mentors who are sitting here for that is how I have built my practice. Thank you very much.